Which is your first slide?
This one, ma'am.
Yeah. Dr. Varsha, you can see the slides, no?
Yes, yes.
Yeah, okay. So there's still 3-4 minutes. We'll start at sharp 11. Huh? Let some more people join also. Yeah. Dr. Shaurav, which college madam was asking, you're doing DNB. Just you can introduce yourself in the meantime. Yeah.
Yes, ma'am. Good morning, ma'am. I'm Dr. Shaurav Khanna. I'm a fellow at PD Hinduja Hospital and Research Center. I'm doing my 2-year fellowship over there.
Okay, you're doing the 2-year fellow. And where you have done your MD or DNB from where?
I did my MD from SRMC, Sri Ramachandram Medical College in Chennai.
Okay. Fine.
Good morning. Hello, madam. Good morning.
Hi, Dr. Durga. Good morning. How are you?
I'm fine.
You want to check your slides now? We have about 2-3 minutes before we start.
Yeah, I suppose I'll just.
Yeah.
So,
Shaurav, can you stop sharing the screen?
I've stopped sharing my screen, ma'am.
Yeah. Dr. Durga, you can just check then because
yes,
we have the case. You can just
yes,
put
yes,
on
ma'am.
slideshow.
I suppose you can see it now.
Yeah, yeah, and just move it. Yeah, all good. Yeah, yeah, all good.
Right. Thank you. I'll stop sharing.
Yeah, Shaurav, you can again share now, huh?
Hello, Sandeep. Nice to see you.
Sandeep, you are muted.
I have a long association with Sandeep.
Yes. And I'm only going to introduce you. That's my
Yeah,
pleasure.
Great.
Yola, how many years difference? 1 year or 2 years?
In MD, both of
So
us were 1 year
chronologically,
apart.
Yeah, sorry, I missed what. Hello?
Yeah, Sandeep. I suppose we are 1 year apart in MD.
yes, ma'am. Am I audible clearly, ma'am, or my network is slow?
Yeah, right now we can, but which में जा रहा है? ठीक है, you just you can tell your batches which were they here.
Yes. I joined in 2009, and Dr. Durga joined in 2008 for MD.
Okay.
Yeah. Then I spent 4 years elsewhere, and then when I joined HGPGI, he had already passed out from there.
Okay. That's nice. Yeah. So we have Dr. Varsha here from Bombay Hospital, Mumbai.
Hello, madam.
Yeah,
Good morning.
Good morning, Dr.
So nice of you to
Thank you.
join
Thank
the
you.
Yeah, so
Thank you, sir.
yeah. So I think we'll is it time 11 o'clock, Shah? Is it 11 exact?
I think
1 minute to go,
go.
ma'am.
1 minute to go.
Yes.
Okay, we'll just wait for a minute. Yeah. Yeah, so we'll start. It's 11. So, very good morning to all of you. Welcome back to the Maharashtra Rheumatology Association Student Teacher Interface. It's a monthly event, but the last 2 months, because of MRACon State Chapter and IRACon National Conference, we had not held this academic activity. So, we start again, and I welcome you all to this academic session. As before, we have a case presentation first, followed by a guest lecture. For the case presentation, we have two chairpersons faculty, Dr. Varsha Bagul. She's one of the senior most rheumatologists in Mumbai, and she's at present consulting at Bombay Hospital, Mumbai. We also have Dr. Sandeep Kansurkar. He's the Associate Professor of Department of Clinical Immunology and Rheumatology at Bharati Vidyapeeth Medical College and Hospital, Pune. So these two faculty will be chairing the case presentation. After this, we will be having a guest lecture by a very famous young upcoming rheumatologist from SGPGI Lucknow, Dr. Durga Prasad Mishra. The student for today is Dr. Shaurav Khanna. He is MD Medicine from Chennai, and now he's pursuing a 2-year fellowship at Hinduja Hospital, Mumbai. So over to you, Dr. Varsha, Dr. Sandeep, for the case presentation. Yeah.
May I begin, ma'am?
Yes, Dr. Shaurav, we can start. Huh? So they will stop you in between, after history case, like it'll be like a usual case presentation, okay? And we have to finish by 11:50, followed by the guest lecture. Okay, so last few minutes, we can sum up and give a feedback, okay? Yeah, start.
Thank you, ma'am. Good morning, everyone. I am Dr. Shaurav Khanna from PD Hinduja Hospital. I'm doing a fellowship in rheumatology. Today, I will be presenting a case. So, so the patient is a 21-year-old female. She's a student hailing from Mumbai. She has presented with chief complaints of bilateral lower limb swelling since the last 6 months, polyarticular joint pains and swelling since the last 2 months, abdominal distension since the last 5 days, and decreased urine output since the last 1 day. Patient was apparently asymptomatic 6 months back when she started developing a lower limb swelling in both her legs. It was dependent, worsens in the evening. It was progressive in nature. It was non-painful and it was extending below the ankle. It was not associated with any swelling of the face, not associated with any breathlessness, chest pain, palpitations, not associated with any frothy urine and hematuria. The joint pains were polyarticular in nature. They were symmetrical, small plus large joint involvement. They were associated with joint swelling and early morning stiffness of more than 60 minutes. It was additive in pattern, initially involving the bilateral knees and then went on to involve the other joint, which were the bilateral shoulder and the bilateral small joints of the hand. The symptoms would improve with activity and worsen with rest. She also complained of abdominal. She, al- she also complained of abdominal distension since the last 5 days. It was associated with constipation and obstipation since the last 1 day. It was not associated with any abdominal pains, and there was no history of jaundice, uh, uh, nausea, and vomiting. The decreased urine output was not associated with any frothy urine, hematuria, or dysuria. There was no history of any malar rash or photosensitivity. There was no history of any fever, loss of weight, loss of appetite. There was no history of any oral ulcers, alopecia, no history of sicca, parotitis, no history of Raynaud's, dysphagia, skin tightening, no history of headache, confusion, seizures, no history of any proximal muscle weakness, any cough, breathlessness. There was no history of any heavy menstrual bleeding and no history of any bleeding per rectum. Coming to the past history, there were no history of any similar episodes or similar complaints in the past. No past history of any tuberculosis. No past history of any comorbids like type 2 DM, systemic hypertension, and thyroid disorders, and no significant past surgical history. There was no history of inflammatory
Sure.
arthritis.
Yeah, there was a little break. You can just repeat the last one or two sentences. Yeah.
Yes, ma'am. There was no past history of any tuberculosis in the patient, no past history of any comorbidities like type 2 DM, systemic hypertension, and thyroid disorders, and there was no significant surgical history. There was no history of any inflammatory arthritis in the family. She had a menarche at 14 years of age, and her menstrual history has been comprising of regular menstrual cycles with no particular history of heavy menstrual bleeding. She was unmarried, consumed a mixed diet, denied any addictions, and there was no significant drug history in the past. Coming to the treatment history, she was
I
worked
think,
up.
Dr. Saurav, with this history, what is your, I mean, what are you thinking of? How would you approach this patient?
Ma'am, she has come to us with bilateral pedal edema with inflammatory joint pains, with abdominal distension. I would like to think of a multisystemic involvement comprising of joint pains and maybe renal involvement, serositis.
Mm.
I would like to think
See,
of maybe.
serositis is okay because she has lower limb edema for more than 6 months.
Yes,
The
ma'am.
joint pains have come much after that, na?
Yes, ma'am. I would like to take a examine further
So
and
generally with the multi-system involvement, you would have fever as a predominant symptom to start with, no? There
yes,
are no
ma'am.
systemic complaints.
No, ma'am.
There's no periorbital edema, nothing else, na?
No,
It is
ma'am.
just edema limited to both the lower limbs.
Yes, ma'am. No periorbital or facial edema.
Any skin lesions on the lower limbs?
No, ma'am. There was no skin lesions in the lower limb.
Dr. Shaurav, how would you like to elaborate on etiology of pedal edema based on history?
Based on history, we can have pedal edema due to cardiac causes, renal causes, hepatic causes. Anemia in failure can also present with pedal edema. Venous insufficiency can also lead to pedal edema.
So,
In
clinically, I mean, on
this
history, how
patient,
do you find out which?
If the
Suppose
patient
it's
presents
cardiac,
with-
what would happen? If it's hepatic, what would happen?
okay, ma'am.
The
If the
distribution of the edema would vary, na?
Yes, ma'am. If the patient presents with a cardiac cause of edema, patient will present more with pedal edema first. And if it was because of a renal history, the swelling of the face and periorbital puffiness would be a presentation. If it is because of hepatic cause, ascites would be the presentation.
Any other condition
Can
can lead to bilateral lower limb edema?
Venous insufficiency can lead to bilateral.
Anything else more common in a young female?
Anemia can present.
So anemia is basically won't cause only lower limb edema, right? Any endocrine cause you can think of?
Hypothyroidism can present.
Yeah, so hypothyroidism sometimes can present only with edema feet. Okay.
Can arthritis lead to pedal edema?
Yeah.
Yeah, yes, sir. Arthritis can lead to pedal edema.
How will you differentiate this arthritis-related pedal edema from other systemic causes? That was my intention of asking this question.
Sir, arthritis will present with pain while using the joint. Whereas pedal edema without arthritis, the joint movements will be painless and normal, sir.
So see, he's not talking about, Dr. Kansurkar is not asking about ankle joint involvement. Patient has edema feet and patient has inflammatory arthritis. So how would
Yes,
be the
yes.
edema
Here,
in patients with inflammatory
yeah.
arthritis?
Edema will probably be non-pitting.
No, this is the examination finding. On history, your patient has got both arthritis as well as edema. On
Yes.
history, how will you get to know that
Sir,
this edema is most likely because of systemic causes or arthritis?
Edema, which is more severe in the morning, will probably be arthritis related, whereas pitting, I mean, due to systemic causes, it will present more in the evening.
That edema would be limited to the joints now.
Yes.
It
Yes.
wouldn't be, you have
Yes.
below leg edema, right? Below knee. You said below knee, na? The edema is below
Yes,
knee,
ma'am.
right?
Below the ankle, ma'am.
Below ankle. Foot edema.
Foot edema.
So then it would be very what, painful, na?
Painful edema, yes, ma'am. And it will also
Yes.
like arthritis related edema will involve only the joint related areas. Non-joint involvement will be there in systemic causes of edema.
So is there any cause why patient has arthritis for many years and then develops edema feet? Is there any? See, this edema has come before the joint pains, right?
Yes, ma'am.
So if you have a patient of, say, for example, inflammatory arthritis, like rheumatoid arthritis, going on for years together, and now comes with huge lower limb edema. Can you think of anything
Untreated
which
RA,
is not painful? Which is not painful.
untreated RA, like we can have renal involvement, amyloidosis, they can present with pedal edema.
Yeah. So that is one condition, but that would come many years after the inflammatory arthritis. It would not precede or it would not be with the joint pains.
Yes, ma'am.
Right?
Yes, ma'am.
Most of the systemic edema usually will be dependent edema. So if you with a limb elevation and postural correction, most of those edemas will subside. But the inflammatory edema is unlikely to subside by these maneuvers. This can be one of the points which can differentiate it. And what can be the if her age would have been suppose a 70 old lady coming to you with similar complaint of arthritis and pedal edema, especially which is the painful edema, what may be your differential?
Sir, old patients presenting with arthritis and pedal edema, like a lot of old patients will have comorbidities. They can have renal involvement. They can be pedal edema because of that. Prolonged anemia because of the chronic disease can present with pedal edema as well.
No, arthritis.
Okay, I would add a hint. If that edema is coming and going, for some days it stays there, some days it goes off. So what can be the condition?
Sir, there is a condition called relapsing symmetrical synovial polyarthritis. In that, we can have such a presentation.
Yes, also
RS
called RS3P syndrome, where
Yes,
we have synovitis as well as pedal edema, which
pedal
is
edema.
typically relapsing.
Even in an elderly patient, you can have a lot of varicosities, you know.
Yes,
And because of that can be a postural edema and venous insufficiency.
And they can have
Go ahead.
gout with CKD, so they'll have pedal edema with them. They can renal involvement in multiple myeloma. All these can have inflammatory joint pains also.
Yes, yes.
Yeah.
Shall I proceed, ma'am?
Yes, yes. Proceed.
Okay. Coming to the treatment history, because of these symptoms, she was worked up by the local GP, and he had done a CBC, which revealed the hemoglobin to be 5.5. And he had managed her with 2 doses of IV injections, probably parenteral iron therapy. And for her joint pain, she had seen another doctor who had also treated her with short course medicines for her symptoms, which were oral iron, torsemide, and ketorolac. And she was also transfused 1 PRBC outside. Coming to the summary, we have a 21-year-old female with no known comorbidities who was presented with a 6-month history of pedal edema, 2-month history of symmetrical polyarticular small plus large joint inflammatory arthritis with a 5-day history of abdominal distension and 1-day history of oliguria. with severe anemia on investigation. Shall I proceed with examination, ma'am?
Yeah, I
Yeah,
want to know what is your thinking behind the abdominal swelling?
Sir, abdominal swelling can happen
What is the
because of
etiology?
the severe anemia, because of failure. Because the anemia is so low, in the absence of any blood loss or acute event, uh, we cannot rule out a hemolytic anemia. The presence of inflammatory arthritis and hemolytic anemia can make us think of a CTD as well.
Ascites doesn't happen, you can get cardiac failure and all. Just pure anemia will not cause so much of ascites.
ascites, yes.
Distension, yeah. And you should give your provisional impression, no, after the summary before going on to examination.
Sorry, ma'am.
Yeah.
Shall I go ahead, sir? Shall I proceed, sir?
I think tell us what you're thinking of, no, at this point of
Yes,
time.
yes, yes. Sorry, I had a
So what is
stability
your
connection
working
in between.
diagnosis? I mean,
Uh, I would like to work up the cause for anemia, and in the presence of the symptoms, inflammatory arthritis and like if it is a hemolytic anemia, I would like to rule out a autoimmune etiology, maybe a CTD.
Would you like to be specific about CTD?
Uh, Systemic lupus erythematosus can present like this, sir.
Yes, yes. So SLE is definitely a differential diagnosis in
You
this
can
case. You
say
can be
that.
confident on it.
Yeah, you can
You
say
can be confident on it.
only what goes against SLE in this patient?
There is no fever, there is no mucocutaneous
Systemic
manifestation.
complaints are not there.
skin is not involved.
Skin is not
Should
involved, there
it
is
make
no
you
fever.
more comfortable or more concerned when there is no photosensitivity or no skin manifestations in lupus?
Um,
Is it good or bad? Or, I mean, anything to worry?
like it can be a bad sign, can suggest organ involvement. I'm
Actually,
not
it
sure.
can be
I don't know, sir.
actually it can be reversed. When skin manifestations are present, patient may be harboring raw antibodies, which can be actually protective in terms of nephritis. That's a better antibody. Second thing, detection rate of patient is higher when skin manifestations are present. Rather, it helps patient reach out to the doctor earlier, and probably the patient may get diagnosed earlier. Those who don't have skin manifestations actually have been seen to be performing worse as compared to those having skin manifestations.
Okay, sir.
Yeah. Go ahead.
Yes, ma'am. Coming to the general examination, patient is conscious and well oriented to time, place, and person. BMI is 21. She was afebrile at the time of examination. Pulse rate was 120 beats per minute, regular in rhythm, normal volume with all peripheral pulses being felt. Blood pressure was 100 by 70 millimeters of mercury in the right upper limb. Respiratory rate was 20 cycles per minute. Saturation was 97% on room air. Head to toe examination revealed pallor was present. Pitting pedal edema was present up to the ankle. There was no raised JVP, no evidence of any icterus, clubbing, cyanosis, lymphadenopathy. There was no alopecia, no skin rash, no oral ulcers, no redness, swelling, tenderness in any of the joints, no Raynaud's, no digital ulcers.
Anything in the nails you would like to mention?
Nail bed telangiectasias can be seen. Patients with inflammatory arthritis, we should look for nail pits for psoriatic arthritis. Nail changes of psoriasis are
In this patient?
um, um, Nail bed telangiectasias we can see in CTDs like scleroderma.
Iron
So,
deficiency?
yes, ma'am. We can have onycholysis and
You have platinecchia, no?
yes,
That
ma'am.
to tell you that the anemia is of a longer duration.
Yes, ma'am.
You know the duration of since when the patient is having a low hemoglobin. So platinecchia straight goes to favor of iron deficiency anemia and the long-standing anemia.
Okay, ma'am. Yes, ma'am. Shall I go ahead, ma'am?
So Raynaud's, I mean at room temperature,
Yes, ma'am. Like
no Raynaud's, and she did not give any history either, right?
no history of Raynaud's in the past.
So can you explain how, like, can you sort of tell us how are the digital ulcers in patients who have CTD? Which are the common conditions where you see digital ulcers?
It is seen more in scleroderma because of small vessel ischemia. We can have pain. The ulcers are often painful.
Often they're extremely painful. Anything else about the ulcers?
Um,
They actually take a long time to heal.
okay, ma'am.
They don't heal so easily, and that's why they're extremely painful. And see, basically these diseases are more common in women, scleroderma and all these conditions, mixed connective tissue disease.
Yes,
So the
ma'am.
patient, she's not able to work, she can't cook, she can't do any of her activities in the kitchen because they're extremely painful. So that's why we need to know this. So we have to educate the patient on how to protect herself from getting this digital ulcer, right?
Yes, ma'am. Yes.
And this Raynaud phenomena won't come in the examination. It comes as a history finding.
Okay.
Examination, you may say cold extremities or something like that, but not.
Yeah, right.
Okay, sir. Okay. Shall I move ahead?
Yeah, go ahead.
On systemic examination, on inspection, abdomen appeared distended, umbilicus was flat.
One second, sir. About the oral ulcers, can you tell us? I mean, what oral ulcers are you looking at in this patient?
There can be painful and painless ulcers, and based on the distribution as well. Like in SLE, the ulcers are more on the palate and the buccal mucosa. Medication, I mean, nutritional deficiencies and aphthous ulcers are also common. They will have painful. They will be painful
They're
in
very
nature.
painful.
Yes.
So you have to
painful.
mention no oral ulcers, no palatal ulcers also. So when you,
Okay, ma'am.
that's why you should actually examine the palate because you can see this, and they tell us that the disease is active. These are like small signals the body gives, to tell us about the activity of the disease.
Yes, ma'am. Yes, ma'am.
Okay, go ahead.
Why did you ask for clubbing? I'm just being curious here. Why did you examine for clubbing in this case? Was there anything specific clue for you?
IBD can present with clubbing. ILD can also present with clubbing.
Yes.
You can have pseudo clubbing in scleroderma because of skin changes.
Pseudo clubbing is not just because of skin changes. What happens to the terminal phalanx to give that clubbing-like appearance in scleroderma? You get an acroasteolysis,
Yes.
pulse space resorption. That's why the nail becomes curved.
It appears as though there's clubbing.
Pseudo club, yeah. Yeah. Sandeep, anything else you had in mind for clubbing? Yeah, I think continue. Yeah.
Coming to systemic examination, abdomen appeared distended, umbilicus was flat, there were no visible scars, dilated veins, there was no tenderness, guarding rigidity, no organomegaly on palpation. Shifting dullness was present, bowel sounds were absent, there was no renal bruit. Respiratory system, cardiovascular system, and central nervous system were all within the normal limits.
Patient had shifting dullness, no?
Yes, ma'am. Patient had shifting dullness.
Well, I would like to have the cardiac examination actually in detail in this case, because there is very much a possibility that some cardiac examination may give you better information about why there is ascites in this case. So it can be just pass on cardiac examination in this case. There is a pedal edema also. So it has to be a detailed cardiovascular system examination in this case.
Especially with a hemoglobin of
Have you
5.5,
got anything in cardiac examination?
that would be a systolic murmur or
Yeah.
No,
something.
sir. On examination, there was no systolic
Yes.
murmur. There was no raised JVP. Apex beat was in its position, left fifth intercostal space, 2 centimeters medial to the fifth infraaxillary line. The apex beat was in place, sir. Sorry, ma'am.
JVP?
JVP was not raised, ma'am.
Yeah. So, yeah, Sandeep, you can ask regarding cardiac, more questions.
So what are the cardiac causes that may be present in this case, which can explain your arthritis, pedal edema, and ascites?
Sir, we can have serositis, so pleuropulmonary effusions can be present. They can lead to, like on examination, you can have muffled heart sounds, raised JVP.
Yes.
So that's basically pericardial involvement.
Yes. Shall I move on to the next slide? Case summary.
What is
So
the cardiac involvement in lupus like?
maximum will be pericarditis. There can also be myocardial involvement. And a lot of patients with long-standing SLE, they can have comorbidities like systemic hypertension, which can contribute to atherosclerosis and coronary artery disease.
Anything more than that? So it's basically a pancarditis, na?
Yes,
Can be a
ma'am.
myocarditis, pericarditis, and there can be endocarditis, right?
Yes.
What is that called? The endocarditis that they get?
Liebman-Sachs endocarditis.
Yeah.
Does your patient fit into myocarditis?
In your history tells you that there could be an element of myocarditis. Your examination findings.
I'm sorry, ma'am. I'm sorry, ma'am. Can you please repeat the question?
Something in your examination which you told us, general examination, anything fitting into myocarditis or?
No, ma'am.
That marked tachycardia, no?
Tachycardia can be the only thing.
Here, I think you're done with your systemic examination.
Yes, ma'am.
Yeah. Should also look for tremors and all those things, with tachycardia, whether there's a thyroiditis, which can also give rise to joint pains, which can give rise to edema fiat. So
Yes,
don't be
ma'am.
preoccupied with one diagnosis. So when you see tachycardia, the next thing is you look for tremors or look for the neck examination and general examination. Is there any goiter?
Yes, ma'am.
Okay. So it could be lupus with autoimmune thyroiditis. We don't know.
Yes, ma'am. It can.
So Dr. Sandeep, you want to ask something?
Yes, go ahead. Let me ask the question.
Coming to the case summary, we have a 21-year-old female with no known comorbidities presenting with bilateral swelling of the feet since 6 months, inflammatory arthritis from the last 2 months, abdominal distension since the last 5 days, and decreased urine output since the last 1 day. And on investigation outside, it was revealed that the patient had a severe anemia. On examination, she has tachycardia, bilateral pitting pedal edema up to the ankle, pallor, along with moderate ascites and absent bowel sounds. So
You did not elaborate about the joints. You said she has inflammation.
That I was
On
waiting for actually.
examination?
on examination, it was normal. She had taken NSAIDs outside, and when she had presented to us, all her joints appeared normal.
There are no joint pains, all movements are normal.
Oh,
Yes, ma'am.
Yeah, actually, I would expect here the separate sheet explaining the joint examination, whether there was swelling, there was tenderness, or a clear-cut mentioning about the musculoskeletal system examination.
Acha, there was no slide on MSK examination.
No, and
No, ma'am.
you have to elaborate on that.
Yeah, just go to the next slide. Yeah, it's
Sorry.
not there. Next slide.
How would you differentiate? Next slide, next slide.
Yeah, it's not there. Yeah.
Yes, ma'am. How would you differentiate your inflammatory arthritis from rheumatoid and lupus? Other
In
CTDs, rheumatoid and other CTDs in general.
rheumatoid will present it with a erosive form of arthritis, and in CTDs we may have more of arthralgias with joint pains and the stiffness being more predominant over the joint swelling. In CTD, in SLE especially, there is no erosive arthritis. Patient is less likely to have, not likely to have deformities. If at all there is deformity, it could be because of Jacquard's arthropathy, because of laxity of ligaments.
Generally, with 2 months history, maybe deformities may not come in, na?
Yes, ma'am. It won't
Deformities
come.
sometimes will take time.
Takes time.
You should elaborate on the joints because that was one of our chief complaints.
Sorry, ma'am.
So, what is the major issue in this patient as per your assessment now, which needs a primary focus?
Sir, her anemia has to be addressed, and we have to work up the cause for the ascites, whether it is due to systemic involvement, whether it is due to anemia. We have to work that up. The anemia and the ascites, and even the oliguria. These three will be the main points of focus while working up the case.
I will explain the oliguria. How commonly you get to see the oliguria in lupus?
I'm sorry, sir. I couldn't hear the question. Sorry, sir.
Oliguria in
How common
lupus.
you get to see the oliguria in lupus?
Not very common. If the patient has a very bad renal involvement, like nephritic syndrome, we are likely to see it in end stage.
It's a very rare scenario.
Yes, not very
And
common.
for me, the do you think the patient is having an acute inflammatory state as of now? Because patient has also got tachycardia, pallor, and joint pain also, and reduced urine output. Probably, I may also look for some infective cause also in this.
Yes, sir. Yes, sir.
You think it could be autoimmune hepatitis going into cirrhosis, liver failure?
The presentation was not with the ascites, it was more with pedal edema that goes against it. There was no history of any jaundice or any jaundice in the past, or any symptoms of liver cell failure also in the patient on examination.
How long she is taking NSAID? You just told that she is taking NSAID because of it.
Sir, 5-day history just before she presented to us.
Can you tell us few
Can you-
signs that you see in chronic liver failure? This is an MD question, but then you.
We can have alopecia, we can have gynecomastia, we can have icterus, we can have spider nevi, we can have breast atrophy in females, gynecomastia in males. We can have signs of coagulopathy like ecchymosis. We can have a axillary hair loss, loss of secondary sexual characteristics.
Get parotid enlargement.
Parotid enlargement in alcoholics. We can also have Dupuytren's contracture in alcoholics.
Which is a joint which is like in lupus and rheumatoid, na, both you would have a small and large joint involvement, right? As you said, it is non-erosive, non-deforming in lupus, and in Rheumatoid, it is erosive. Any particular joint which is more involved in rheumatoid, like if patients have that joint involvement, no, it's RA, it cannot be anything else.
Rheumatoid, wrist, ma'am, wrist.
Wrist can come in lupus also. These are temporomandibular joints. Generally, when you have a TM joint involvement, yeah, in addition with other inflammatory joints. Any other subtle joints that are affected, which are not obvious visibly, like you cannot visible, but they can cause, there can be inflammation there also. If the patient of RA started complaining of severe hoarseness of voice, what do you think? Which joint is getting involved? It's a cricoarytenoid not joints, right?
Cricoarytenoid.
Okay, then these patients can also have some amount of deafness because of involvement of the small joints in the ossicle joints in the ear, auditory canal, right?
Neck pain, if they have neck pain.
Yeah, neck pain.
C1 atlantoaxial involvement.
Joint involvement, right? So if a rheumatoid patient complains of backache, what do you think it is?
Generally, back involvement is very rare. It is most likely to be due to non-rheumatological causes, like maybe mechanical disc-related disease like that.
Or suppose it is a severe backache. A patient of rheumatoid comes with severe backache, acute onset severe backache, not able to move.
Maybe it is
not radiated, no radiculopathy, so not a disc issue.
Maybe he's had a fracture, like patients who are on
so osteoporosis, no?
long-term treatment may have osteoporosis.
Patients receive a lot of steroids, sometimes with knowledge, sometimes without knowledge, and then even a severe bout of cough can cause a collapsed vertebra. That can be extremely painful.
Yes, ma'am.
So, I think
so apart from this lupus, do you have any other differential diagnosis which can explain things in this patient?
Apart from lupus, the duration of the history is very is not short, and there's no fever, so infective causes are less likely. IA with inflammatory arthritis with anemia could be a possibility, like a rheumatoid arthritis or psoriatic arthritis with long-standing anemia. That can be another differential.
But ascites, how will you measure?
How will you get ascites? Can everything be explained on the basis of anemia? Just is it a case of severe anemia and everything related to anemia?
Everything can be just by severe anemia. Yes.
But arthritis, how will you explain with just pure severe anemia?
I'm sorry, sir. Can you please repeat the question, sir?
But arthritis, you may not be able to explain with just severe anemia.
Yes, sir. We will not, because arthritis will, like, the chronic anemia doesn't lead to severe anemia and doesn't lead to failure usually.
Can it be just Cox with Ponson's arthritis and?
Yes, sir. Reactive arthritis, but against TB would be the absence of fever and absence of constitutional symptoms, sir.
So what is Ponson's actually?
Yeah, it can be possible.
How is the
reactive arthritis which occurs during active tuberculosis infection?
Basically, it comes with the infection, or it comes after starting treatment for the infection?
It comes with TB, ma'am.
And what is the kind of joint distribution that you see? Is it?
It will be lower limb predominant, and it will be
more of a reactive arthritis.
Yes, ma'am. Lower limb predominant, oligulo-articular, not polyarticular.
So
more commonly it sets in after the anti-TB drugs are started.
Okay.
Will be the two most priority now you will go for in this patient?
I'm really sorry, sir. Your voice is cracking, sir. I wasn't able to hear.
Yeah, Sandeep, we can't hear you. I think he's asked which is the most important investigation. That's what you've asked?
Yes, for two most important investigations you will advise. Two, right?
Yeah.
Ma'am, two important investigations in this case, sir.
Most important, yeah.
Like one would be inflammatory markers and were serologic and serology, sir. ANA blood.
First basic investigation, which will give you a lot of information.
CBC peripheral.
So a complete
peripheral
hemogram
count.
is most important, na?
Yes, yes, ma'am.
How would it help you?
It will help us to classify the anemia, whether it is because of chronic disease, whether it is because of iron deficiency, whether it is because of nutritional deficiency, hemolysis, like that, to just find the cause for anemia.
Okay. So suppose this is a patient of rheumatoid. What would the CBC show?
It will show a normochromic, normocytic anemia, thrombocytosis. Counts will be normal. It will be elevated in flares.
And what would happen in a patient with lupus?
Lupus will show pancytopenia. It can show only autoimmune hemolytic anemia. It can show just cytopenia, just thrombocytopenia. Sorry, ma'am.
For me, the most important investigations would be a peripheral smear and urine routine microscopy. That can give me the four most important information that I'm looking for in this patient.
Yes.
Yes, yes, sir. Yes, sir.
And in lupus patients, what would you look in the WBC count? What is more important?
Lymphopenia will be the.
Yeah, so the absolute lymphocyte count is most important, right?
Yes, ma'am.
Okay.
Yeah, so I think we have to wind up in another
10
5
minutes, no?
5 to
10
10 minutes. Yeah.
Yeah. So go ahead with. Shall we go on the investigations?
Yeah.
Yeah.
So when she came to us, these were the investigations. CBC showed a low hemoglobin with a normal MCV and normal counts with normal platelets. ESR was 5, CRP was high, 13.3. Total protein was 7.3 with A by G ratio showing globulins more than albumin, 2.2 and 5.1. Rest of LFT is within normal limits. Creatinine was 1.0, upper range of normal was 1.4. USG whole abdomen was done, which showed moderate ascites, omental thickening, edematous bowel wall. Spleen showed a slightly enlarged 12.6 centimeters with liver showing a altered echo texture.
Would you
Kidney
not do
size.
an X-ray test?
Yes, ma'am. It was done. It was normal. We should do X-ray test.
Because you have a patient with anemia, failure, cardiac failure is one of your
Look
causes.
for like pleural. I mean,
Pleural effusion,
pericarditis.
cardiomegaly, pulmonary edema.
It was done, ma'am. It was normal.
ECG 2D echo was normal.
2D echo was normal. ECG just showed sinus tachycardia.
Okay.
ANA showed a 1:103 plus speckle pattern. Blood showed a SMRNP positivity, nucleosome positivity, histone 1 plus, AMA M2 borderline, and ribosomal P was 2 plus. DCT showed a 4 plus positivity. Corrected reticulocyte count was elevated, 2.5. Immature reticulocyte fraction was also elevated, 47. And reticulocyte proliferation index was decreased, 0.6. C3 and C4 was done, which were low, 14.8 and 1.68. Urine PCR was 2.74. Urine routine showed a 2 plus protein and 2 plus blood. APLA was done, it was negative. Shall I have some?
Varsha, you're muted, Dr. Varsha.
And I said in the CBC, you should have just given the indices, no? MCV and MC.
MCV was normal, ma'am, 83.9. I have some more investigations as well.
So now what is this? Now on investigations, where are you?
On investigations, her CRP is high.
So what does the 5 ESR tell you? Does it give you some?
Generally, we have a CRP which is disproportionately elevated to the ESR in inflammatory conditions. She also has a low hemoglobin. That itself can explain a low ESR.
Is it corrected ESR or gross ESR?
Gross ESR, sir.
No.
Just once. Yeah, we in view of her constipation symptoms, and obstipation, we for one day we got a X-ray of the abdomen after the USG, which showed dilated bowel loops and multiple air fluid levels. We went ahead and we did a CECT of the abdomen. It showed a dilatation of duodenojejunal with duodenojejunal and proximal ileal loops, but there was also a wide zone of transition involving the mid-ileal loops on the left side and the abdomen showing wall thickening. The distal ileal loops and large bowel loops appeared collapsed. The splenomegaly was 13.6 centimeters, slightly enlarged spleen. Liver showed a diffuse fatty infiltration. There was moderate ascites with omental stranding in upper abdomen and multiple subcentimetric lymph nodes. We also got a ascitic fluid analysis done. Cells were high 1150. We wanted to rule out an infection first. We did cultures, TB culture, gene expert, cytology, everything was negative, and it was a high protein, low sag ascites. Because we were aware of intestinal pseudo obstruction which occurs in SLE as a rare complication, but because the CECT showed an evidence of intestinal obstruction with the zone of transition and collapsed bowel walls, we did a diagnostic laparoscopy which did not show any evidence of stricture or obstruction. The liver appeared congested at that time, so a biopsy was done, which showed just chronic hepatitis with ballooning degeneration, not much fibrosis, F1. Liver workup was done for autoimmune hepatitis. They were all normal. And because the UPCR was 2.74, kidney biopsy was done, which showed a class 5 lupus nephritis, membranous glomerulopathy. And the final diagnosis of the patient was a case of SLE with arthritis, serositis, nephritis, autoimmune hemolytic anemia, and pseudo obstruction. And we started treatment with 500 milligrams of methylprednisolone IV for 5 days, and we followed it with a 30 mg taper. We started her on HCQS as well, and we started her on mycophenolate as well, keeping the nephritis in mind. On follow-up, the patient improved. Her repeat UPCR was 0.34, CRP normalized, HB also started improving, and she has followed up with us. Last follow-up was just 1 month back in November, when progressively we've had her medicines in a decreasing trend. At present, she's on 5 milligrams of prednisolone, 1440 milligrams, that is MMFS 202, and HCQS 300. This is her trend of blood reports. We can see the acute phase reactants have improved. The C3, which was very low initially, has started normalizing. Urine PCR also is under check. Yes, this is my last slide, sir.
So this is a common problem, clinical problem. So differentiate between lupus serositis versus TB abdomen. So how will you differentiate between these two types of ascites?
I'm really sorry, sir. Can you please repeat the question?
How,
Sir,
How to differentiate between the lupus serositis ascites and ascites because of TB abdomen?
Sir, ascites because of TB will be exudative in nature,
This
whereas
will be also exudative. Lupus ulceratis will also be
Both will be exudative.
exudative.
so there's a low sag, no?
we can do microbiological testing. We can do TB
That
culture.
is also negative in most of the TB abdomen. Also, you won't get anything in microbiological testing also.
Um, uh, cells, new lymphocyte predominant, that will also be there in lupus.
Yes.
In lupus also. ADA?
ADA levels will be low in high in lupus, high in TB, low in lupus. That yes, ma'am. And concurrently, C3 blood levels, C3 in the blood may be low. We can have other multisystemic involvement, which may not be seen very commonly in TB. Concurrent clinical features can help in differentiating both the ascites.
TB abdomen
In
will only
lupus,
have
you,
ascites, no? May not have
yes.
edema and all that.
Yes, ma'am. Yes, ma'am. Will not have
Yes.
edema of the.
And also concurrent pleural effusion goes in favor of polycerositis. If you have a double site effusion, that goes more in favor of lupus. You look at the lymph node, abdominal lymph nodes. If you're seeing necrotic lymph nodes in abdomen, probably you are dealing with a
TB.
TB abdomen kind of scenario than lupus. Okay. And ADA definitely, as you suggested, can help you in differentiation. And if nothing helps you, then actually, well, if you start treatment, TB as this ascites because of lupus resolves very fast with the start of treatment, while OX may not resolve at all once you start the treatment for lupus. So this may be some cues.
I think we'll just conclude, I think, huh? Dr. Varsha?
Yes.
Yeah.
I think very nicely presented, sir.
Thank
Yeah,
you.
little small things you have to elaborate. Like the patient had chief complaints of joint pains and you forgot the musculoskeletal examination, so that should have been kept in detail.
Yes, ma'am.
Otherwise, it was a good presentation. I think we would have discussed more on the investigations and treatment, but we're running short of time. Start
Yes.
sharp.
Good presentation.
Yeah.
Yeah.
Thank you. Thank you, Dr. Kavita.
Thank you, Dr.
Thank you.
Varsha. Thank you, Dr. Sandeep, Dr. Shaurav, for the presentation. It went off well. Now Dr. Saurav, stop sharing your slides. Yeah.
Yes, ma'am. Thank
I
you.
invite Dr. Durga for his talk. Dr. Durga, you can start sharing your slides, and I request Dr. Sandeep. They are alumni from the college days. So you can please introduce our guest speaker for today, Dr. Durga. Yeah.
Yes. So it's my pleasure to introduce Dr. Durga. So we have a long association. He was my senior during MD. So so he has done his MD medicine from SCB College, Cuttack, and then DM from SGPGI Lucknow. So he has also got multiple accolades like FRCP Edinburgh and MSc in epidemiology, and he has specific research interests in Takayasu arthritis, vasculitis, and cardiovascular risk in rheumatic diseases. He has got IRA Young Rheumatologist Orientation in 2019, and also he has got visiting professorship at Rafinavelu Subramaniam Endowment Oration in 2026 upcoming. He's also a member of steering committee of UDAR recommendation for large vessel vasculitis and polymyalgia rheumatica. He's also executive committee member of Indian Rheumatology Association, and he is an editor for multiple rheumatology journals, or most of them are top-notch journals in rheumatology. And it will be a pleasure to actually listen from him on his favorite topic, Takayasu arthritis. Over to you, Dr. Durga Mishra.
Thank you, Sandeep, and thank you, Kavita Madam, for the invitation to speak on this topic, which is close to my heart. So we shall be discussing about disease activity and damage and management of Takayasu arthritis. So we shall be having the talk in two segments. So I do not have any disclosures. To start with, assessment of disease activity and damage in Takayasu arthritis. It is challenging to clinically assess disease activity or damage. What we would like to believe is Takayasu arthritis progresses from a phase of pre-pulseless Takayasu arthritis to that with pulse loss. But what actually happens in real life is that the difference between disease activity and damage is much more nebulous. The classical triphasic pattern of disease, which we believed was common, has now been refuted to be uncommon. From this study from US, they found that those having a triphasic pattern, that is constitutional symptoms followed by vascular symptoms and then major ischemic events, was less than 20% of their cohort. And in our analysis of our cohort also, we found that those who are pre-pulseless, they tend to remain pre-pulseless. They don't really most of them don't develop pulse loss over time. So it's not that a pulse loss always means damage or presence of pulses always means activity. Absent pulses also reappear in about a sixth of patients with Takayasu arthritis. These are mostly older studies wherein corticosteroids alone were used, and a considerable proportion of patients with Takayasu arthritis actually have reappearance of pulses after treatment. The traditional acute phase reactants poorly reflect disease activity in Takayasu arthritis. From the classic study from the National Institutes of Health in the mid-90s, it was found that elevated ESR was present in 72% with active disease and also in 44% with inactive disease. And then they looked at patients who had undergone vascular surgery, which is generally taken up when the patient is clinically inactive and that time with normal ESR. Of these patients, 4 out of 9 patients had active vasculitis and biopsy, thereby indicating the fallacies of peripheral blood inflammatory markers to identify Takayasu arthritis disease activity. And similarly, another series of 33 patients from France who underwent vascular surgery, 42% of them had either active or chronic inflammation, despite clinically inactive disease at the time of surgery. So how do we assess disease activity clinically in patients with Takayasu arthritis? The classical tool was described by the National Institutes of Health, wherein the presence of 2 or more features, which were either new onset or worsening, whether systemic features or an elevated ESR, as per the NIH criteria greater than 20, or features of vascular ischemia or inflammation, and typical angiographic features. If they were new or worse compared to the last visit, then one could say that a patient had active disease. However, since this requires a comparison with the previous visit, by definition, one cannot use this at the initial visit. Then work from India devised 2 scores, the disease extent index in Takayasu arthritis, which scores features that are new or worse in the past 6 months, and the Indian Takayasu clinical activity score, the ITAS 2010, which scores features that are new or worse in the past 3 months. So there is weighting for certain features, for example, cardiovascular features. If you can see here, if there is a carotid bruit that is new, then you automatically get a score of 3. One for the presence of bruit and other for the specific carotid bruit. So certain features are weighted. However, the issues with the ITAS are the exact cutoffs for disease activity have not yet been defined. Some take greater than equal to 4, other have defined greater than equal to 1. And there is a poorer concordance with physician global assessment for initial visits, and this improves from the 3rd visit onwards. So the ITAS and DITAC remain work in progress. The trials of abatacept in giant cell arteritis and Takayasu arthritis in 2017 proposed certain criteria which included either presence of fever or symptoms suggestive of vascular inflammation or vascular ischemia, or presence of constitutional symptoms with an elevated ESR or CRP. What was important to note that if there was isolated elevation of ESR or CRP without clinical symptoms, they did not consider it to denote disease activity. So also new onset vascular stenosis or dilatation on angiography also denoted active disease. Of note here, when we think of angiographic progression in patients with Takayasu arthritis, the American College of Rheumatology and Vasculitis Foundation in 2021 came up with guidelines which say that if there is a new arterial territory that is involved, that might indicate active disease. However, if there is an increase in stenosis or increase in dilatation in an already affected segment, one cannot be certain whether this is active disease or whether it's simply remodeling changes that occur in the inflamed arterial wall over time. So the EULAR recommendations in 2018 proposed to use the term relapse rather than a flare, and relapse was defined as signs and symptoms of active Takayasu arthritis along with any of these 3 features, that is disease activity on vascular imaging or histopathology, or vascular ischemia due to disease, or persistent elevation of ESR-CRP without any major explainable cause. And major relapse was defined as if there was evidence of active aortic inflammation resulting in either aortic dilatation, stenosis, or dissection, whereas the absence of this denoted a minor relapse. Now, coming to the concept of damage in Takayasu arthritis. So damage by essence denotes something which is not amenable to treatment. And till recently, we really did not have a tool to either assess clinically the damage. Clinical damage could be disease related, which could be events like stroke, bowel ischemia resulting in gut gangrene, myocardial ischemia, pulse loss or limb claudication, or ischemic optic neuropathy, or could also be treatment related, like osteoporosis, cataract, weight gain. The large vessel vasculitis index of damage was recently published for patients with Takayasu arthritis from Tanas Kirmani and colleagues. And now we have a validated tool to clinically assess damage in patients with Takayasu arthritis. With respect to angiographic assessment of damage, we shall come to that a little bit later, and there are various different scores that have been described for this purpose. So the large vessel vasculitis index of damage, which was published earlier this year by colleagues from the US, showed that patients with Takayasu arthritis at presentation had considerable amount of damage. And there was also a proportion of them who had incremental damage upon follow-up. So clinical assessment of disease activity in Takayasu arthritis could be using various disease activity scores. Damage could be assessed using various scores. Until recently, we did not have a validated score for Takayasu arthritis, but now we have the LIVID, the large vessel vasculitis index of damage, which as of now is actually undergoing revision to have a better version that can better denote damage in these patients. And also we have patient reported outcomes. Circulating markers of disease activity, we have already seen the fallacies of ESR and CRP, and there are various circulating proteins, circulating cell populations, which have been explored in patients with Takayasu arthritis. But actually, till now, there is no gold standard that provides a circulating biomarker of TAC disease activity. With respect to angiographic assessment of disease activity, what one must understand is that arterial wall thickening is a characteristic feature of patients with Takayasu arthritis. On the right side, you can see these CT angiography images of the thoracic aorta. And if you see this part of the top image, posteriorly, you can see a cuffing of tissue around the aorta. And here in the lowermost image, you can see the left carotid that is almost narrowed to a lumen that's about a fourth or a fifth of what it usually would be. And you can see the thickened arterial wall around it. And similarly on ultrasound here, you can see that around this blood flow, there is this hypoechoic area. And this is the top images of the ultrasound are in patients with active disease, where you can see that this is somewhat hypoechoic, the wall thickening, the intima media thickness. Whereas in patients with chronic disease with probably residual damage, you can see that the arterial wall in the lower images is fibrous and somewhat hyperechoic as compared to the images on the top. So angiographic assessment of Takayasu arthritis can tell us three things. One, the anatomy of the arterial tree through either CT angio, MR angio, or color Doppler ultrasonography for accessible vessels. Arterial wall characteristics through either contrast enhanced MR angio or diffusion weighted MR angio without contrast, but this is technically difficult. Through CT angiography and through color Doppler ultrasonography, and also through a specialized technique of contrast enhanced ultrasonography. And arterial wall metabolic activity could be indicated through PET. Classically 18F-FDG PET, but as we shall see now, newer tracers are being evaluated, such as somatostatin 2 receptor and fibroblast activating protein inhibitor PET. So the different angiographic modalities, the advantage of CT angio is that it's easy to do. It hardly takes time, hardly takes 5 to 10 minutes. However, there is considerable radiation exposure and requires contrast administration. And this cannot be done in patients with renal failure, and same issue with MR with contrast. MR without contrast does identify the anatomical extent of vascular involvement and can be used in patients with renal failure. However, it is time intensive. And diffusion weighted imaging, which is a specific technique, may help to identify vascular wall disease activity even without contrast. The advantage of PET CT and more recently PET MRI is being used is that it allows in vivo imaging of the metabolic activity in the arterial wall. And through new ligands, you can potentially explore pathophysiological processes that are actually occurring in the arterial wall. However, PET-CT is associated with considerable radiation exposure, which is lesser with PET-MR, but still the PET per se has radiation exposure. Color Doppler ultrasonography, the advantage being that it's non-invasive, no radiation exposure, but requires a degree of technical expertise. And it's also technically more difficult in obese individuals and difficult to image deep-setted vessels, such as the thoracic aorta, which is practically impossible to image with color Doppler ultrasonography. The various scoring systems using angiography in Takayasu arthritis include the angiographic stenosis score, the angiographic dilatation score, and the angiographic composite score, all described from the late Justin Mason's group from London, wherein they have evaluated these using CTA or MRA. Then you have the combined arthritis damage score, which can again be done using CTA, MRA, or PET-CT. The color Doppler ultrasound score from Kolkata from Professor Alakendu Ghosh and colleagues, wherein you can assess the flow pattern in 19 arterial segments if it is normal or abnormal, that is if it's biphasic, monophasic, or there is no flow. And you can summate these scores to provide the CDUSK. And the PET vascular activity score, or the PET VAS from the NIH, which assesses PET uptake in each of 9 segments from 0 to 3 based on a comparison of the uptake in the liver, and summation of this scores provides the PET VAS. And more recently, a PET MRI specific vasculitis activity score using MR PET has also been described, wherein you can have the SUV means for all the arterial territories along with certain MR characteristics which indicate arterial wall disease activity. So metabolic imaging markers of TAC disease activity are coming up in a big way. One must understand that the inflamed arterial wall in patients with Takayasu arthritis is metabolically active even during phases when the inflammation has settled in. There is ongoing fibrosis, and these can be explored in vivo using PET techniques. So 18F-FDG PET is the classical one that has been used in patients with Takayasu arthritis. So what you have is the standardized uptake value, or the SUV, which can be compared with the liver to grade it from 0 to 3. And there are other measures also, such as the target to blood pool ratio or the target to liver ratio. And we have also devised 2 scoring systems extrapolated from the use of PET in oncology, the metabolic inflammatory volume and the total inflammatory glycolysis, to summate the quantum of PET uptake in the arterial wall. So how does active large vessel vasculitis differ from atherosclerosis? Generally, in active large vessel vasculitis, you have more of a diffuse uptake, whereas in atherosclerosis, it is focal areas of uptake which are high. Whereas in the large vessel vasculitis, you have more or less a diffuse uptake of the arterial wall. So this is a case of a gentleman who presented to us with 4 months of left upper limb pain on activity and weight loss and new onset of hypertension. His inflammatory markers were absolutely normal. And you had this left upper limb pulse, which was lost. So clinically, he was Takayasu arthritis, but it was intriguing that his inflammatory markers were normal. When we did a PET-CT, there was florid uptake in the aorta and its branches. And when we looked up the literature, actually, this is not surprising. This study, the one seminal study from Justin Mason's group, shows that those with a positive PET or a negative PET have essentially similar values of ESR and CRP. And therefore, PET possibly picks up a subset of active Takayasu arthritis where traditional markers of inflammation such as ESR and CRP are negative. So when you have these arterial grafts, at those areas, there can be persistent uptake on PET. So you should not think of that as active disease. That is one thing that you need to keep in mind when assessing the PET uptake. And the important message here for the residents is that PET provides, 18F-FDG PET provides complementary information to that provided by ESR and CRP for the assessment of disease activity in Takayasu arthritis. Of note, if a patient has been on a glucocorticoid dose of greater than 5 milligram prednisolone for 3 days, then there is a reduction in PET uptake. So if you are unable to get the glucocorticoid dose to below 5, there is not much use doing a PET-CT to assess disease activity. You'll have to rely on the inflammatory markers, the clinical scenario, and the other imaging parameters comparison with previous. So greater than 5 milligram of prednisolone dose dampens PET arterial wall uptake. And this study from Carlos Alvar and his group from Italy showed that if there is a PET uptake as compared to arterial wall thickening on CT angio, the risk of developing incident stenosis, the area under curve is almost 0.8 if there is a PET uptake in that arterial territory. Whereas if there is arterial wall thickening on CT angio, then the area under curve is only 0.52, which is just like tossing a coin. Basically, it doesn't predict future development of stenosis. So FDG uptake, but not arterial wall thickening on CT angio predicts future stenosis. And this was another study from the National Institutes of Health, wherein they showed that compared with a arterial territory on the opposite side, which did not have FDG uptake, if there was FDG uptake in the arterial territory, the risk of developing angiographic progression was, odds ratio was almost 20. And recent ligands that have been explored on PET are the somatostatin 2 receptor, which localizes in the arterial tissue corresponding with sites of macrophage infiltration, and the fibroblast activator protein inhibitor. This pilot study published in Rheumatology Oxford earlier this year showed that a proportion of patients who were in remission continued to have uptake on FAPI-PET. So the clinical relevance of SST2R PET and FAPI-PET are yet uncertain, and these are areas that one would look forward to in the future. So the imaging assessment of disease activity in Takayasu arteritis relies on angiography, PET, and ultrasound. What is the way forward? Till now, we have seen there is no perfect assessment marker of disease activity in Takayasu arteritis, and today, the only thing that remains the clinician's best tool is the physician global assessment of disease activity. A paper published a few years back in Rheumatology Oxford assessed that a combination of ESR, SUV mean on PET, and the serum IL-2 receptor increased the prediction of active disease versus inactive disease as compared to the NIH score, or what is called as the Kerr score. So the way ahead is combining information from different modalities to derive a composite disease activity score. And in this context, the Takayasu Arteritis Integrated Disease Activity Index was recently published from the NIH, wherein they look at these different arterial territories. If they have these symptoms to suggest involvement of these arterial territories, or if they have constitutional symptoms, then they look at whether there is PET uptake in those arterial territories, or in case of constitutional symptoms, if there is ESR or CRP elevation. And only if both these two parameters are present would they score this as a point. And this had moderate correlation with physician global assessment and patient global assessment. So this is an important tool that's coming up, the tie-dye. One must beware depression and anxiety as mimics of TAC disease activity. And this was another gentleman who, on follow-up, developed new onset fatigue, generalized weakness, myalgias, elevated ESR. No new vessels were involved. CT angio was similar to before. And when we undertook a PET CT to look for hypermetabolic foci in the large vessels, it was absolutely silent. Going back, when we reviewed his history, he had tearfulness, increased anxiety, decreased appetite, decreased energy. So what he had was depression, which could easily mimic Takayasu arteritis disease activity, and these symptoms improved after starting him on sertraline. So patient-reported outcomes are also worse in patients with Takayasu arteritis. In our cohort, we have seen that patients with Takayasu arteritis have higher depression and anxiety scores when compared with healthy controls. So I'll conclude this segment with the messages that assessing disease activity remains challenging, and please don't rely alone on ESR or CRP. And in a patient on glucocorticoid less than 5 milligram or not on glucocorticoids, then 18F-FTG PET is a very important tool to assess disease activity. And composite multimodality disease activity scores are probably the way forward. Now coming to the segment on management of Takayasu arteritis, would you like me to take any questions at this stage, or do we take it at the end?
We'll take it in the end, I think. There are 4 or 5 questions.
Right.
Yeah.
So I'll proceed with the management of Takayasu arthritis. So we shall briefly look at the pharmacotherapy, corticosteroids, DMARDs, any role for adjunctive therapies like statins or antiplatelet agents, surgical interventions, role of comorbidities with respect to prognosis of patients before we conclude. So with respect to corticosteroids, how effective are corticosteroids in Takayasu arthritis? So we undertook this systematic review with meta-analysis a few years back. A lot of studies were older studies because nobody uses corticosteroids alone anymore. But we found that about 60% patients had a clinical response when you treated them alone with corticosteroids, but more than a half, about 2/3 of them relapsed. So that's the issue when you treat corticosteroids alone. The patients relapse once you get them off corticosteroids, and hence that's the reason why you combine corticosteroids with DMARDs upfront. What dose of corticosteroids to use? This very important study from CMC Vellore published about 7 years back in Seminars in Arthritis and Rheumatism showed that those patients treated with a corticosteroid dose of 0.5 milligram per kg as opposed to 1 milligram per kg at presentation, they had similar rates of relapses. So in most patients, one can actually manage with a prednisolone dose of 0.5 milligram per kg per day. With respect to DMARDs, we have few RCTs in patients with Takayasu arthritis. Two of them compared abatacept or tocilizumab versus placebo. Another one compared mycophenolate versus methotrexate, and another adalimumab versus tocilizumab. So this was the tocilizumab in Takayasu study, which looked at subcutaneous tocilizumab 162 milligram weekly versus placebo in 18 patients with Takayasu arthritis. And on the primary intention to treat analysis, although the hazard ratio was 0.41 for tocilizumab versus placebo for relapse-free survival, the upper limit of the confidence interval crossed 1. Therefore, the study did not attain statistical significance. However, on a secondary per protocol analysis, the hazard ratio was similar, 0.34 for benefit of tocilizumab versus placebo, and the upper limit did not cross 1. So although the study failed in its primary outcome, it did show that there was a considerable reduction in relapses when treated with tocilizumab as compared with placebo. There was another trial that came in 2017 comparing abatacept versus placebo, and there was absolutely no difference in relapse-free survival between abatacept or placebo. Mycophenolate versus methotrexate was a randomized controlled trial from CMC Vellore. And in this, on the per protocol analysis, the primary outcome of clinical response at 9 months was similar between mycophenolate and methotrexate. And so also were a number of secondary outcomes, including angiographic stabilization, which were similar for both the drugs. Another recent study compared adalimumab versus tocilizumab, wherein 21 patients were treated with adalimumab and 19 with tocilizumab. And at 6 months on the intention to treat and per protocol population, adalimumab had better effectiveness rate than tocilizumab. However, for a number of secondary outcomes, the outcomes were similar, and the study was at high risk of bias due to some concerns about randomization and the lack of a pre-published statistical analysis plan. Therefore, when you have this one endpoint that's different, but the others that are not different, it's difficult to conclude whether adalimumab was really superior to tocilizumab or not. A summary of results from different observational studies show that overall with DMARDs, whether conventional or biologic, there is about 80% patients that have a clinical response and about a similar proportion that have an angiographic response. And relapses occur in about 15 to 20% patients. Adverse events occur in about 15 to 20% patients. Head-to-head studies comparing DMARDs, methotrexate was similar to mycophenolate. We have seen the RCT already. And methotrexate was similar to cyclophosphamide. Leflunomide was better than cyclophosphamide. Leflunomide compared to other DMARDs was similar. Leflunomide was similar to methotrexate. One study shows that add-on hydroxychloroquine may have lesser risk of angiographic progression, but no other studies look at this. And biologic DMARDs versus conventional DMARDs, a meta-analysis of 2 studies showed similar outcomes with either. Tocilizumab versus cyclophosphamide, better clinical response with tocilizumab and worse adverse events with cyclophosphamide. Tofacitinib versus methotrexate published in Annals of Rheumatic Diseases in 2022. Tofacitinib was better for certain clinical outcomes like clinical remission and fewer relapses. However, angiographic progression and adverse events were similar in both groups. Tofacitinib versus leflunomide, both were similar. Secukinumab versus TNF inhibitors, both were similar. And this recent study from Turkey showed that methotrexate and azathioprine in newly diagnosed patients were similar. And this study from Brazil looked at leflunomide versus adalimumab. And for the primary outcome of complete response at the last follow-up visit, both were essentially similar. So the American College of Rheumatology recommendations had a conditional recommendation that for TAC that is refractory to glucocorticoid alone, they recommended adding a TNF inhibitor over adding tocilizumab. We assessed whether this really holds true with respect to the available literature, and we did a systematic review with meta-analysis, and we found that both were essentially identical with respect to clinical responses, angiographic stabilization, or adverse events. So as of today, there is nothing really to prefer TNF inhibitors versus tocilizumab. The usual strategy would be to use these drugs along with tofacitinib in patients who have a refractory disease. Intravenous versus subcutaneous tocilizumab, one study has addressed this, and the clinical effectiveness at 6 months was similar for either. However, the risk ratio for relapses were higher with subcutaneous than with intravenous tocilizumab, with the caveat that few patients were on subcutaneous tocilizumab in this study. With respect to adjunctive therapies, a retrospective analysis suggests that statins might reduce future risk of relapses. Antiplatelet drugs are generally used in patients with Takayasu arthritis with cerebral or coronary ischemia, or following interventions. You generally have them on dual antiplatelet for 3 months to 1 year, and thereafter a single antiplatelet agent should be continued for life. With respect to surgical interventions, there are specific indications for surgical interventions which include critical organ-threatening ischemia such as myocardial ischemia, stroke, ischemic optic neuropathy, or acute mesenteric ischemia, or if there is chronic ischemia affecting quality of life, for example, limb claudication, which is limiting activity of the patient, if there is chronic mesenteric ischemia resulting in weight loss, refractory renovascular hypertension or subclavian steal phenomena, or if there are vascular complications like severe aortic regurgitation or aneurysms, which may be at a risk of rupture. In our experience, about a fifth of patients with Takayasu arthritis require interventions, and it must be noted that interventions should be undertaken during periods of inactive disease and while continuing with immunosuppressive agents. We shall see the evidence for this a couple of slides later. So this is our experience, wherein about a seventh of patients had undergone interventions, and about 1/7 of these interventions actually required to be repeated because there was restenosis. And this is a study from the cardiology unit of CMC Vellore, which shows that repeated interventions tend to be associated with better outcomes than the primary patency. As you can see that over time, the primary patency of an intervention comes down. This was a study from China, which looked at 46 patients who had undergone surgical treatment or angioplasty and compared complications or death among those treated with corticosteroids, which were 1 in 24, versus those not treated with corticosteroids. 50% of them had complications, including death. And those with active disease, all 8 had complications, whereas those with inactive disease, less than 10% had complications. So again, the message that I would like to reiterate is any intervention should be undertaken in patients with Takayasu arthritis at a time when the disease is inactive and with the continuation of immunosuppressive therapies in the perioperative period. Now, there are specific scenarios where one might think that interventions are required. So one is coronary artery involvement, and the literature suggests that revascularization or medical treatment have actually similar outcomes with respect to survival. However, with respect to major adverse cardiovascular events, fewer major adverse cardiovascular events are observed with those undergoing coronary artery bypass grafting than those undergoing percutaneous coronary intervention. So if possible, these patients should be referred for coronary artery bypass grafting. With respect to pulmonary artery involvement, this study compared survival in those who had undergone endovascular treatment along with medical therapy or medical therapy alone. And they found that there was better survival with endovascular treatment than with medical therapy alone. So now comparing endovascular versus open surgical interventions. So overall, the risk of restenosis is higher for endovascular interventions, and this also holds true when you look at the individual coronary, the territories like the coronary artery, the supraaortic arteries, or the renal arteries. However, the risk of perioperative stroke is increased with open surgical intervention. So that's the trade-off. So although open surgical interventions have fewer restenosis, but there is a greater risk of perioperative stroke. But this does not translate into an increased mortality risk with either of these. So the risk of mortality is similar, but the risk of perioperative stroke remains higher with open surgical interventions at the cost of fewer restenosis. Now comparing stenting versus angioplasty in patients with Takayasu arteritis, overall across the different arterial territories, both are similar. However, for the renal arteries, it has been noted that angioplasty is associated with fewer restenosis rates than stenting. But the clinical efficacy with respect to control of hypertension is similar, and the risk of vascular complications is higher with angioplasty than with stenting. So that's why many centers would prefer to undertake an angioplasty, a balloon angioplasty alone for renal artery involvement, then go ahead with stenting if that fails. But again, the risk of complications is higher with stenting alone, with angioplasty alone. Comorbidities, infections and heart failure are important comorbidities in patients with Takayasu arteritis. And when we analyzed our cohort, we found that these were associated with increased risk of mortality. And therefore, appropriate measures should be taken to prevent infections through vaccinations and to optimally treat heart failure. So I conclude with these take-home messages that a dose of 0.5 milligram per kg prednisolone daily appears to be as effective as higher doses for induction of remission in Takayasu arteritis as well as for prevention of future relapses. There are no successful RCTs of DMARDs versus placebo in Takayasu arteritis. And actually, one can choose any of the available DMARDs other than cyclophosphamide, which for some reason appears to have worse effectiveness and higher toxicity as compared to most other DMARDs. With respect to those patients with refractory disease, TNF inhibitors and tocilizumab have similar outcomes, and tofacitinib is also an emerging option for these patients. Limited literature suggests that statins may reduce the risk of relapses, and there are specific surgical indications for surgical interventions. And open surgical interventions have lesser restenosis but increased risk of stroke, whereas endovascular interventions are similar outcomes for angioplasty and stenting for the different arterial territories, except for the renal arteries, where angioplasty is better than stenting for restenosis but is associated with more complications. Thank you, and questions are most welcome.
Yeah, thank you, Dr. Durga. It was a very lucid presentation, and your two parts were very well timed regarding the regarding the disease activity and the management. I'll first just discuss some questions in the chat box. Elevated ESR and CRP with no activity on imaging, MRI / PET. How to decide further course of management, especially if the patient is asymptomatic, to change or to observe?
If a patient is asymptomatic, has simply got elevated ESR or CRP and no angiographic progression or no activity on PET, then I would simply observe the patient. I would not change immunosuppressive therapy. I would definitely not hike up immunosuppressive
Not
therapy.
hike, yeah. Does narrowing seen on CT angiography reflect the disease activity or just stenosis, regardless of disease or damage?
So if you remember the study that I had discussed from Carlos Alvarani's group in Italy, they had looked at patients who had undergone PET as well as CT angiography and assessed further angiographic progression in those segments which either had PET uptake or had arterial wall thickening on CT angiography. So what they found was if there was 18F FDG PET uptake, the area under the curve for development of a future stenosis was 0.8, which is reasonable good prediction. Whereas if there was arterial wall thickening alone on CT angio, then the area under curve for the prediction of stenosis was 0.52, which is simply like tossing a coin. So actually arterial wall thickening on CT angio does not necessarily reflect active disease. It may evolve in the future also. The narrowing may become worse, but that might simply be due to vascular remodeling. The arterial wall stenosis might also reduce on its own and sometimes become aneurysmal. But that's again due to remodeling, because if you remember the figure that I had shown, the inflamed arterial wall eventually develops into a fibrosed arterial wall, and it is a highly metabolically active milieu. There is a lot of inflammation going on there, inflammation and fibrotic changes. And this remodeling need not reflect ongoing disease activity. So we are still uncertain as of today what this means and how to go about understanding what to do with these patients. So if there is arterial wall thickening alone, I would not think this is disease activity.
So, I mean, you have to do a PET CT in all, like, and what frequency, or like, it's an expensive investigation, not available also everywhere.
Yeah, what I do is if a patient has come to me with and is not on immunosuppressive therapy, has come to me for the first time, I would definitely do a PET CT. What I find is doing a PET CT actually changes my baseline assessment of disease activity. Whenever I see a patient, I document whether the disease, as per my physician global assessment, is active or inactive before doing the PET or before doing the inflammatory markers. And after doing the PET, about a third of these patients who are active, I denote them as inactive. And again, a third of them who are inactive, I denote them as active. So it helps me to optimize the decision of assessment of disease activity. And I think if you trade off the fact that if you think the patient has active disease and you give them few years of immunosuppressive therapy, I think the cost of PET, it's also coming down nowadays and it's getting more and more accessible. I think the trade-off is financially also beneficial to the patient in the longer run. But in a patient on immunosuppressive therapy on glucocorticoid greater than 5, you can't rely on a PET. Then you'll have to decide based on whatever you have, based on the history of the patient, based on any prior imaging, then it becomes more difficult.
So, as I understand, first you would prefer a PET CT, especially a patient who is not on steroid. And the follow-up, what would you recommend?
Follow-up, what I usually do is at 6 months to 1 year, I do a PET CT as well as a CT angio at baseline. All the recommendations say you do an MR angio, but it's difficult in my place to get MR time. That's the reason why the waiting lists are too long. So I do a CT angio at baseline along with a PET CT, and at 6 months to 1 year, I would repeat a CT angio.
Okay.
And if the disease is stable there, then maybe once 2 to 3 years later, another CT angio, and then not again, unless there is a clinical relapse.
So, do newer molecules like FAPI show better uptake than FDG, especially if a patient is on steroid? Does it make a difference?
It's not possible to comment on this at the moment because the literature is so scant.
New, FAPI is
Yeah,
new actually.
So we are yet to understand what FAPI uptake on the arterial wall actually means.
Okay. When do you say there is inadequate response to tocilizumab? After how long? Or again on CT angio? Or
So response to tocilizumab, one must take care that once a patient is on tocilizumab, you cannot rely on the ESR and CRP anymore, because the CRP is a direct effect of IL-6 on the liver. And once you knock out IL-6, the CRP comes down. And also this IL-6 affects the levels of fibrinogen, which is reflected by the ESR. So ESR and CRP are no more reliable markers of disease activity in a patient on tocilizumab. So you would have to rely on the clinical response and possibly evolution of angiographic changes. It's often possible in retrospect to say that this patient was active 6 months back when you have an angiographic progression. But as of today, that's the way you would have to assess a patient on tocilizumab if you want to. If there is a clinical response, maybe not go for an angiography. If there is no clinical response and you want to change a treatment after 6 months or 1 year, maybe repeat an angiography and see what were those vessels that were affected before. Are they getting more and more stenosed, or are they similar? If they're similar, then maybe the disease has gone into remission. Otherwise, you might have to change another agent.
so ESR will not rise if a patient is on tocilizumab, but what if it actually rises? Like I had a patient on tocilizumab and the ESR became 3 times. So would you do a CT angio here or?
If the patient has any clinical suggestion of disease activity, only then would I do that. If the patient has clinically gone into an inactive phase of disease, then I would not bother about any ESR or CRP elevation.
In a patient with symptomatic single coronary artery involvement, how long would you wait after starting immunosuppression before considering endovascular involvement?
If cerebral ischemia is symptomatic, I would like the patient to be taken up for intervention.
Coronary.
Couple of weeks. Oh, coronary, is it? Oh, sorry. Coronary, then one would have to intervene because immediately, along with corticosteroids, start the patient on corticosteroids and intervene as early as possible, because you don't want the possibility of a myocardial infarction developing.
So both go parallel. Here you don't have to wait.
Yes, you don't have time.
Management of active TAC along with the patient who has pulmonary tuberculosis. I think, yeah.
Yeah, this is actually a challenge because when we looked at patients who had developed serious infections in our cohort, about a fifth of serious infections had developed in patients who are not on immunosuppressive therapy. So these patients seem to be predisposed to serious infections like tuberculosis, and it is not uncommon. I would say if I assess 20 patients for disease activity with comprehensive assessment, including a PET, about 1 or 2 of them might have active tuberculosis along with active disease. If it is not life-threatening, for example, like coronary artery involvement or cerebral ischemia due to active disease, then I would wait for at least the induction phase of anti-tubercular therapy to be completed before starting the patient on immunosuppressive therapy. But if it is,
yeah.
but if it's like coronary artery involvement, then you have to do everything simultaneously.
Atherosclerosis versus TAC. I think this is also another common scenario. On CT pan aortogram, close mimic. So how to differentiate and proceed with treatment?
Yeah, for this actually, I learned from my late cardiology colleague that if you have extensive atherosclerosis, sometimes it becomes difficult to distinguish whether it's just atherosclerosis or it was Takayasu leading to atherosclerosis. But if your coronary arteries are normal, it is likely that it was large vessel vasculitis. So that's one distinguishing point. But otherwise, I have patients who have presented at the age of 55 to 60 with diffuse atherosclerosis and no symptoms. And this was picked up incidentally, and probably they had large vessel vasculitis, although there's no way to go back and prove that because the disease is inactive at present. But if the coronaries are spared with a diffusely atherosclerotic involvement of the aorta, then it's likely that patient had large vessel involvement before.
So you would do a FDG PET here or you would not?
The patient did not have any symptoms, so I don't think it's, this was simply incidentally detected. So Yes, for this patient, we did do an FDG PET and it was inactive. It did not show any disease activity at that moment.
How do you proceed in a young patient with diffuse atherosclerotic findings in CT angio, mildly elevated acute phase reactants? I think a little similar to the previous one, only they've said this is a young patient.
I would
Isolated.
look for a suggestion of familiar hyperlipidemias. If they're not there, then it's likely large vessel vasculitis.
Okay. Can MMF and methotrexate be combined in a patient not affording biologics?
Yes, I do combine because many of our patients cannot afford biologics, although the scenario has changed after tofacitinib has come in. But I do combine mycophenolate with methotrexate when either of these agents is not successful alone to control disease activity.
If I can
But there are
remember,
no recommendations for this. No recommendations for this. It's just personal experience.
if I can remember correctly, one of your slides talked about combination of tofacitinib with biologics. You said add.
No, there was not a combination of tofacitinib with biologics, but yeah, in this context, I now remember there was an abstract in ACR this year, 2024. It's not yet a published paper. This looked at MMF plus methotrexate at 15 milligram per week and MMF up to 2 gram per day. This was an RCT actually from China, compared with cyclophosphamide, monthly cyclophosphamide, followed by azathioprine in 111 patients, a large number of patients, and they found that the MMF methotrexate was better than the cyclophosphamide. So actually now there is some data emerging, but this paper is not yet published.
So which are the combinations you use, like when you use combination therapy for immunosuppression?
Basically, it's difficult to combine methotrexate or azathioprine. Tacrolimus is another agent that one can use because there is some data about the effectiveness of cyclosporin. So one can combine tacrolimus with methotrexate, tacrolimus with mycophenolate, or MMF and mycophenolate. Or in today's world, it's better to try out tofacitinib, although the data regarding the effectiveness of tofacitinib is not yet fully established, but it remains an option that's more accessible than biologics as of today.
So you can give tofacitinib upfront also with severe TAC before biologic, like just after steroids.
I would not prefer to give upfront. If you remember, one of the slides had shown a meta-analysis of 2 studies comparing biologics with conventional DMARDs, not targeted synthetic DMARDs. These studies were 2017 and 2020, and both had similar effectiveness. So I would upfront start with a conventional DMARD alone. And tocilizumab, although the literature suggests it's a good agent, somehow the risk of infections in our patients is quite high. Whatever couple of patients I have tried on tocilizumab, one developed dental abscess with sepsis, and these infective complications make me hesitant to use in my patient population tocilizumab, although it's a good agent.
And how long do you use it if you use tocilizumab? Because cost is also an issue.
Yeah, it's maybe for a year along with other conventional DMARDs and try to get it down after a year.
And how often have you used adalimumab with for attack?
I have tried adalimumab on 3 patients, but the results have not been very optimistic. Only one of those patients responded. And when I talk to my colleagues from Europe, they actually prefer to use infliximab. And sometimes what they say is they go to supratherapeutic doses also. They reduce the dosing of adalimumab to weekly or infliximab. They increase the dose up to 10 milligram per kg.
There's one last question here. Any insight on sirolimus in Takayasu?
There is rationale to possibly use sirolimus in Takayasu arthritis because the activation of the mTORC pathway has been associated with arterial wall fibrosis, but there is no clinical data to support the use of this drug. It is investigational. Maybe data might emerge in the next 5 years or so.
Okay. Any more questions by anybody? You can ask Dr. Varsha. Okay, I think
wonderful presentation, Dr. Durga. Thank you so much.
Thank you, madam.
Excellent.
Very elaborate.
Yeah, Dr. Varsha, sorry, continue.
Yeah, that's it.
Okay, thank you so much, Dr. Durga, sparing your time on Sunday. And it was really an excellent presentation and very good discussion. And there were a lot of questions. If any more come, I'll send it across to you.
Yes, yes. My pleasure, madam. Thank you.
Thank
you
you
so much.
everyone for joining us today. Yeah. Okay, happy
Thank you,
Sunday.
Dr. Kavita, for organizing this wonderful Sunday
Yeah,
program.
thank you
Thanks
so
a lot.
much.
Bye-bye.
Bye-bye. Yeah.
Thank you, Dr. Sandeep.
Thank
Bye.
you. Thank
Okay.
you.
Bye, Dr. Varsha, Dr. Sandeep, Dr. Durga. Yeah.